Forget frequently asked questions.
Common sense, common knowledge, or Google.
How about advice from a real genius? 95% of people in any profession are good enough to be qualified and licensed. 5%
go above and beyond.
They become very good at what they do, but only
0.1%
are real geniuses. Richard Jacobs has made it his life's mission to find them for you. He hunts down and interviews geniuses in every field: sleep science, cancer, stem cells, ketogenic diets, and more. Here come the geniuses. This is the Finding Genius Podcast
with Richard Jacobs.
Hello, this is Richard Jacobs with the Finding Genius Podcast. I have Archana Bandi. She's part of the University of Pittsburgh, clinical director, part of Telehealth Services at the VA Pittsburgh Healthcare System. We're going to talk about some of the work that she's doing, and she's also brought along one of her patients to talk about some specific outcomes that he's had. So thanks for coming, Dave. Thanks for coming, Archana. I appreciate it.
Sure, no problem.
So, Archana, tell me a little bit about yourself and your work, please.
So thank you for this opportunity, Rich, for Dave and I to share the work that we have done. So I'm an endocrinologist by my clinical craft, and I take care of patients with mostly chronic diseases. And as you may be aware, there's a projected shortage of endocrinologists across the country, while the prevalence and cost of diabetes continues to rise. So this creates a huge gap for patients in accessing the right care at the right time. So what's unique to my work environment at VA, where I am, is that we have a system built in hub and spoke pattern, where a very robust primary care network is embedded across the country where veterans live, and the specialists are located in central hub locations. So patients usually have to travel long distance, but what we have done very successfully at VA is we have used the tools of telehealth and deliver the care for veterans closer to their home. So we've done a pilot study about 11 years ago, studied the electronic consultation services. And based on those results, VA as a system has rolled out e-consult services across its own networks.
Oh, nice.
Yeah.
What was it like before when patients would have to go to the VA and with their long lines to be seen?
Exactly. The wait times were long. Patients had to wait. Doctors, the system just were very fragmented. The groundwork for electronic consultation was always there. So with a formal e-consult service, as we call, we really established a network where patients, physician, and patients themselves could get an answer for smaller problems and sometimes even complex problem without having to travel.
Well, this year with COVID, it looks like telehealth has been opened up across state borders. Is that going to impact what you're doing in Virginia or not at all? Or Pittsburgh, I'm sorry.
Oh, COVID has really pressed the reset button across the healthcare. It's a watershed moment. Really, the healthcare system is the only service, I should say, in our country where technology had not trickled down to bring its best fruit to us. And what COVID has really taught us that we were ready for a significant part. So it's changed how we're doing things. And e-consult is just one part of that. The story of telehealth is going to continue to grow. And here at VA Pittsburgh Healthcare System, we make the care be available to patients where they are, and we try to do best possible. And that's what most of my work focuses on. And I take endocrinology as my sandbox to create new programs and really transform the healthcare delivery, so to speak.
So you're an endocrinologist, but do you tend to see thyroid cases, or do you deal with diabetes more? Like, what are the top few conditions that you need to help patients with?
Yeah, so diabetes really lends itself very easily to telehealth. That's bulk of my telemedicine work. But there are certain conditions such as thyroid disease, follow-up of osteoporosis, chronic management of obesity, patients with high cholesterol, high lipids, especially the chronic care, the longitudinal care, it does lend itself very well to telehealth.
So when did the telehealth consults, when were they approved and when did they start happening?
So e-consult really took off in 2011 for veteran health affairs for us. And now they're part and parcel of our care. What we do is now goes beyond e-consult. We do video clinics to patients' home, and we do the video teleconferencing to our patients who are located in remote areas where they come to their primary care office and be triaged by local nurses and be seen by a physician such as me who is located hundreds of miles away. And it really took off in 2012 and 13. So we have very mature programs now.
But in Pittsburgh, I don't think they call it a tri-state area, but I know it borders, like, you have West Virginia there and you have a couple states.
Mm-hmm.
So now telehealth restrictions seem to have been lifted where you can do it across state lines. Is that helping you to reach more of your population, or was it not a problem?
So that was not a problem for us. We are a federal system, and these legal aspect of crossing the border are usually driven by state medical boards and apply to non-federal healthcare systems. So for us, for example, David lives in West Virginia. My patients come from as far as central Pennsylvania, eastern Ohio, upstate New York. That probably was the reason we were so successful in expanding our programs. Once we realized that we could do it and we had the tools to do that.
Oh, excellent. Okay. Well, David, would you be okay
Yes.
if I hear from you a little bit? What's been your experience with the VA, and has it changed recently, or has it been good or bad? Like, give me a few ideas.
Yeah, over the past 20 years plus that I've been with the VA, I can't say enough good things about the entire system. I mean, I myself personally have never had a problem with the VA. They've always given me excellent service and excellent care. Physicians like Dr. Bandi, just absolutely phenomenal people that are available for healthcare. And with them, with the program of the telehealth and video conferencing and those kind of things, to where folks like myself are kind of distant from the medical centers for the VA, like in Pittsburgh or Clarksburg or whatever, that's a quite distance to go. It affords us the opportunity to be able to do one-on-one with our physician as if we were sitting in the office right there with them. So I think it's very important that even with the COVID or whatever, once that hopefully disappears or we get it under control, that the VA will continue those and give the veterans the option as to what they want to do as far as traveling a distance to see the physician in person or doing, say, a video conference. In my opinion, it's just as good.
Yeah, what have you noticed being in person, doing the video conference? Like, what have you noticed of the differences?
I really don't see a lot of differences. I mean, I can see the physician, they see me. We can interact with each other the same as if we were sitting in a room. So I really don't see a lot of difference at all.
Well, they can't listen to you with a stethoscope yet, but at least they can talk to you and do all the other stuff.
Yeah, the standard, typical kind of, examination, I guess they can't do over a video conference. But there again, that's usually, heart rate and blood pressure and that's not a whole lot other than that, unless they physically examine you for some particular reason. And if they have a particular reason that's something that's out of the ordinary, then of course you can always go see them in person if you need to. And if you don't have, I don't think you're missing a whole lot on the other end of the spectrum where you have video conferencing available.
And actually, Rich, you'll be surprised to know there are digital tools such as digital stethoscope, digital otoscope that can send information right from patient to physician. For example, we have a home hemodialysis program. A home hemodialysis, not peritoneal dialysis. Home hemodialysis, where the machine is very compact machine is at patient's home, and patients are provided tools to check the pulse on their buoy at the fistula to see the viability of fistula. Patient can transmit all the information through cloud-based services to a portal. it's really come along with the biometrics, the transmission of biometrics through a remote monitoring program that we have here at VA. And there are many companies coming along.
I guess as an alternative, what you could do is you do the telehealth session with the patient, and if they need, physical stuff done, they could always maybe go to a local clinic at worst, and then that could be transmitted to you guys, the main center in Pittsburgh. But if you can do it at home totally with devices that use the cloud, that's even better.
That's what happens for most part. It's actually with COVID, we're delivering care to patients home when possible. If not, for example, David's care, this would happen in a clinic where he would have a nurse sitting in the room with him who could do the brief physical exam for me in person there, and I could watch her do the physical exam and report me the findings that she's having. And this applies to other specialties as well. You could actually have a local nurse practitioner with the patient if you have a complex patient. So technology can still help us break the barrier of the geography and take the care closer to where patients are.
Yeah, David, you were going to say something about this?
Yes, I was going to say, in my particular case with my diabetes, for example, the VA has provided me with what they call the Freestyle system, to where I can take, and I don't have to stick my fingers so much. I can take readings right off of a sensor that's on my arm that lasts a couple weeks, and then every 2 weeks you replace it. And then I can download that information from my meter to my computer and then upload it to Dr. Bandi, which is what I do all the time before I meet with her. And that way she can review my readings, my daily readings, my monthly, and my last 90 days. It goes up to, I think, 6 months out or back, that she can actually review of all my readings and things with my diabetes, to where she can adjust medications and things like that based off of the information that she's got from the uploads from the system.
Yeah, that's great.
Yeah, there's a lot of good things like that that's available, for veterans and out here that the VA provides that closes the gap a little bit. I think it brings us closer to the physician without actually having to be right there in front of them.
Yeah, my wife uses the Lifestyle Libre, and it's, if you just poked your finger, first of all, it's no fun. And then second of all, you miss out on all kinds of information. Before and after you eat, you can see curves and a lot of data. So, but anything that jumps out at you, since you've been using the CGM, like what, I don't know, has it revealed anything to you like really interesting that made you change your behavior?
I like to be able to pinpoint it for Dr. Bandi, and that's where she really helps me a lot, because, for example, in the last few months, I've had a high blood sugar when I woke up in the morning, in the morning time, which is after being at rest during the night. So I'm not obviously eating anything during the night or whatever that's going to cause that reading to go up. Although metabolically, I guess it can go up from being at rest. But I was having a problem in the morning times, and during the day it would level out and be just fine. So my afternoon readings and my evening readings were good. My morning readings were kind of getting out of control a little bit. She was able to put me on a new medication that I take that has now got those morning readings down to exactly where they need to be. I mean, now I'm really clicking on all cylinders thanks to Dr. Bandi. So that she always, and I'll tell you, my experience that I've had is every single time I've had a situation like that, whether it's Dr. Bandi and some other physicians I've had for other conditions, they've always been able to pinpoint and give me the service that brings it in line where it needs to be physically for me, to where I'm not at risk for anything, and it gives me the opportunity to be flexible, and them to be flexible also, to where we can meet about any time, because it's I think it's more convenient video conferencing.
See, what happens, I would say, is that diabetes especially, it's a team game. It's not a just patient and physician. And with the tools of telehealth, we can build the team around the patient and with the patient. So when we took out, in David's case, for example, the barrier of traveling from Clarksburg to Pittsburgh 3 to 4 hours every day, it makes them more engaged, because now we are available, and through tools of technology, video teleconferencing, transmission of data across the board, it makes patient more engaged, motivated, and gives them more confidence in the care. And as a physician, it's very rewarding to be able to have a team across all working at the same playing field.
If you like this podcast, please click the link in the description to subscribe and review us on iTunes.
Yeah, no, that's excellent. And in general, like what, Dr. Bandi, from your experience being the doctor, how has it changed your relationship to patients?
So I miss seeing my patients in person. I'll be the first one to tell. I'm a people's person. And when you sit across, but what I've learned is that just that face-to-face does not have to be. I can tell you so many stories where if it wasn't for telehealth, the care would not happen for the patient. So, for example, it has reduced our wait times from, 30 days plus to really, we give electronic consultation within 7 days. So if you were the primary care provider asking us the question, in 7 days you will have an answer, or we'll plug in the patient to any of our virtual or face-to-face visits. So that delay in care, if you can address that, that's a huge boon. The other part is that the missed opportunities when patients can't come to the clinic, whether it's inclement weather or somebody sick in the family or can't take the time off work, those barriers go away. They can dial in or connect with us wherever they are. And I think being able to give the care to the patients where they are at the right time when they need it has been the most successful. And I'll tell you another story. Veterans, a lot of them are elderly, and sometimes they have to travel with their family members. And as a specialist, often we'll get, consult request. They would travel all the way. And then I would review the chart and examine them and tell them, I need to do XYZ more tests on you. And they have to go back and get that done. With e-consult, I have an opportunity to review the chart before we even schedule the patient and alert the primary care provider to do those tests. So even if when the patient does travel, it's an efficient visit. It's an efficient visit for me, but more importantly, it's an efficient visit for patients.
Yeah, that's good.
Yeah, to be able to give them an answer, as soon as we can is very rewarding.
Yeah, no, that's excellent. Has it increased your workload or decreased it or just changed the nature of how many people you see a day?
A little bit of both. Nothing happens in void, right? But it has made my work very efficient, I should say. It really has. With e-consult, we have just expanded our access. Our, floodgates opened when we opened our e-consult service. We actually had to create the video clinics in these remote locations because patients were saying, I don't want to travel. You helped me before. If you want to continue helping me, find other way, but I will not travel. I had patients tell me exactly that. But, we had tools. We had financial and personal support to bring telehealth tools such as, the cameras, the specialty card that can transmit the patient's video to my office. So I think I was very fortunate to be working in an environment that was supportive of giving the care and providing the tools that need to make the care happen.
So do you, I guess you'll see patients more often and you'll have hopefully less emergencies or less patients waiting until they're just about to have a massive problem so they come to you earlier.
That's right. So what happens is we have a very robust remote patient monitoring where patients have tools such as the blood pressure, weight, pulse, blood glucoses, oxygenation, and even mental health assessment that can happen daily basis or weekly basis. And these tools are connected to patient's portal via coordinator. So say, for example, a patient sends his blood sugars and they are now rising and he also has a dropping oxygenation. So the coordinator who's getting patient's data can right away call the patient, assess him or her, and either send to emergency room or connect with me right away or the nurses. And we can triage things quite sooner. And it's come very handy in patients with heart failure, in patients with post-op who are going home, and you could monitor their blood glucoses and temperature and things like that. So It has saved bed days of care, so the hospitalization. It has saved the ER visits as well.
David, from your perspective, is there anything else that telehealth can do to make it better than it is? Like what's missing, if anything, still?
The only thing that's kind of a drawback, I guess you would say, for lack of terms, is the filling of the prescriptions. For example, if the prescription changes, it has to be by mail, and it's not an immediate kind of thing like you would go down to the local pharmacy and get it filled right now. It's something that the physician has to submit. The VA pharmacy sends it via the mail. We get it 3 to 7 days later. And I don't know if there's a really good solution for that that I can think of. I think that's the only way they can do it. I think that's the best they can do, or anybody could do actually. But it's a little bit of a lag time with the medication once it's been changed by the physician. By the time the patient gets it, there's a 3 to 7 day kind of lag time in there. However, I have had physicians in some situations where they're needing me, they want me to switch the medication immediately, that the VA overnights it. So they do have the capability to do that if they have to. So I really think that there's not a whole lot of drawback. I'm really happy with the whole system, to be honest with you.
Well,
Yeah, I guess, people can have groceries delivered. They can have all kinds of stuff delivered. So maybe there's a way that the VA will end up partnering with Amazon or local pharmacies where they have runners that they send the order electronically and they run the medication to you in 2 seconds, quick.
Right. I would tell you what where I think we can do so much better, which is bandwidth. The bandwidth of the cell signal is so poor in certain parts of our country, where even if we had all these tools, if patients cannot connect, patients cannot dial in, then this all becomes a moot point. So we as a nation really need to invest a better broadband services just for every sector across schools, hospitals, and patients at home.
Well, can patients use Wi-Fi, or there's a certain number of them that don't even have Wi-Fi or good cell service?
David, do you want to chime in?
Yeah, being here in West Virginia, thank goodness. I mean, out of probably the one state out of all the states that we have in the country, West Virginia, with the mountainous terrain and everything like that, it's hard sometimes to, in the remote areas, the rural areas, to get any kind of broadband service at all. However, some of the new kind of approaches, they're going over the telephone lines with GIOP and the old DSL that's still out there. Although it's slow, it can still give you possible connection. But as far as Dr. Bandi's she's totally on the money. I mean, it's going to have to be better broadband service that gives you wider bandwidth, more communications capability. Otherwise, the video, it's not going to work. I mean, it's going to be staggered and it's going to cut in and out, that kind of thing. And states like West Virginia, particularly with being as rural and as mountainous as it is, it's very difficult in a lot of areas to get that signal to be able to even do a video conference. So in that case, they have no choice. They have to drive, many, many miles to go see their physician.
Do some patients just do audio only? Does that preserve the signal enough, or can they, maybe the VA could show them like designated spots where there is coverage that are only a few miles from them instead of them having to go the whole way?
So VA actually sends them those patients who, don't have through their personal means hotspots or access to cell service. VA does provide them hotspots or say iPad with cell service for them to connect if they can, or clinics, hospitals, nearby hospitals and clinics where they can go. But I'm just talking that as just in general, and maybe it hits me hard because I take care of patients with diabetes and obesity, and these are the two diseases that are much more prevalent in our rural part of our country, where the access to care, especially to endocrinologists, is poor. So I think it sounds like a double whammy to me. But again, because the system I work in has a really good network of primary care offices, I may not feel the pinch as much as any other physician who is outside of this healthcare system would be. Rich, there was a financial analysis done by McKinsey Group in summer of last year. And what they did was through CARES Act, CMS had passed some new billing codes so that we all could continue the care for our patients. These were sort of waived through CARES for COVID coverage. So what McKinsey Group did was they took these codes and applied to all the claims that were put in 2018. And what they came up with is 25%, up to 25% of care that was delivered in 2018 could be virtualized if we really wanted to, based on these codes. And if you convert that into dollar, it's close to $24 billion. And for me, it's the $24 billion is big money, but equally important is imagine if you could do 25% of care through telehealth means the time that it's saved for patients to travel to the doctor's office, sick leave that people have to take, the parents who have to take off work and take their kid to the pediatrician office. The telehealth has potential. What we really need to rally around now is there are many regulatory barriers, and those are the reason the private sector has not A, invested, B, interested in embracing telehealth. None of us go to a travel agent anymore, right? None of us go to AAA to get our trip tick.
Right.
We talk to our astronauts in space station. We're communicating with journalists in the middle of the war in real time. But healthcare is one system where the default mechanism is go to your doctor's office. And I really think that it's 21st century. We need to be able to go to patients' home or closer to where they live as opposed to travel.
Well, what are some of the barriers remaining right now? You said, both you and David seem to say that telehealth's working great. It's reducing travel time and costs, and it's, better, faster care. What's left for it to do? You said bandwidth is important, but what else needs to improve?
A lot. Telehealth has been in shackles because how it's been regulated. The first telehealth bill and law was passed in California in last century. And still, it's been a very hodgepodge. Every state has its own rules and regulation. For now, you could go across the state borders because of the COVID restructuring of the regulation and billing. But pre-COVID era, you couldn't. And such a large proportion of healthcare is happening right now through telemedicine that we cannot go back to pre-COVID era when it comes to healthcare. It's a watershed moment, and it's been just way too long that we haven't made tools of technology part and parcel of care delivery for patients. I just don't see why an 85-year-old patient should be brought in by his 65-year-old son just to hear from a physician that this thing that was seen on your thyroid ultrasound, it's non-consequential. You can be home. Don't worry about it. The lack of interoperability of electronic medical records is a huge, huge issue in getting telehealth on board because we have such hodgepodge status of EMRs that if I'm working in a system where my patients are coming from other healthcare system, I don't have access to their care. There will be duplicity in their care. There will be repeat labs. There will be repeat imaging. And that costs us to the healthcare system. So regulation, lack of interoperability, and acceptance by physician and healthcare system as a whole to telehealth. Those are the major barriers.
When you're going to speak to a patient, I guess you have to review their file before you speak to them, but is that difficult? Is it hard for you to still get all the electronic health records together in one place? What other improvements could there be to make it easier for you and so that you could see a lot more of what's going on with the patient to help them better?
See, for me, not. VA has an electronic health record system that is, so if patient could be visiting Hawaii and ended up in Hawaii ER at VA hospital, I have access sitting here in Pittsburgh. A patient could call me and say, I'm in ER here, and I could look up the chart. Patients who have care outside of VA does get transmitted into our system, but it's the non-VA system. It's the system outside of VA where electronic health records don't talk to each other. There is no like a central repository of medical records. And the one issue that we all will look at, why do patients not have control on their own health records? If I'm paying for my health care, I should have access to my health records no matter which system they are in, right? I should be the owner of my health record.
Well, what I noticed is, my wife's had to do this when, as we're in our 40s, and when she has to go to a new doctor, she has to go around and collect as much of her records as she can. And some of the places are now moved or closed, or, it's just, there is no, electronic central repository for everything that goes with you.
And that's, as a patient, I can see how that frustrating that would be. It's your record, you paid for this healthcare, and you don't have access to your own records. So that's going to be a huge issue when we start embracing telehealth widespread. And I tell you, the consumers are ready for it. The tech enterprise is hungry to create these innovative platforms. But the regulatory aspect of healthcare system really slows things down. I mean, I'm in VA healthcare system. So for us, delivering the care where patient is, that's our value. That's what we want to do. I mean, David used to travel 3-4 hours before telehealth came along, right, David?
Yes, I did.
Yeah, that's crazy.
Yeah, and then
how often were you doing that, Dave?
Oh, it depends on what was going on with me at the time with my condition. If it was out of whack, so to speak, I may have to travel 2 or 3 times a week in order to see the physician to get stuff, back in line where I was good to go, depending on what the situation was. But it's all kind of weather you got to drive in. I mean, like wintertime, you're going in the snow and the ice and all that, just trying to go to see your physician. When you can have video conferencing and they can make a determination and basically fix you, electronically, I think it's great to do the video conferencing.
Yeah, now that's a huge savings. Archana, do you have an idea on average how much time your patients are saving by doing this?
Oh yeah, we did a study just for our e-consult, not even our video programs, and over 240 mile travel per patient was saved. And the time was 4 hours and some 17 minutes. These savings for patients who had electronic consults for their care of their diabetes.
Yeah, that's amazing. That's a lot.
It's a lot. Yeah, we have really upended our traditional diabetes care delivery, Rich. When patients need care from an endocrinologist in our system, in VA Pittsburgh Healthcare System and the smaller hospitals that it supports, the default is e-consult for almost 80% of the patients. And close to 75% of incoming new patients get their care by e-consult first. And then based on the complexity, we can take their care to the video clinics so that they still don't have to travel. Or on a case-by-case basis, we may bring them to Pittsburgh, every 6 months or once a year, something like that. So it's a lot of travel saved, time saved for patients, and most importantly, the care happened in an expedited manner.
So that's great. Well, Archana and David, last remarks. What do you see as the near-term future of this telehealth? Again, you guys both gave ideas. What do you expect is going to happen over the next year or two? Any thoughts?
I'll let David go first.
Okay. I see it expanding. I think that because COVID's a bad situation, but I think because of the situation with COVID, it has put us in the medical community in a position to where we have to rely on the electronic and the video conferencing and things like that. And I think that most everybody out there that does the video conferencing, the e-appointments, telephonic appointments, and those kind of things with their physician when they can, I think they found a big benefit to doing that and saving cost, time of travel, the risk you take at traveling, in certain times of the year, things that you may have a wreck on the way to there. Those things are all avoided by the video conferencing capabilities. And I think it's going to expand in the future, or I at least hope so, to where a lot more can be done with it, that they can afford us more opportunities as veterans for things that we don't have to necessarily go see the physician in person.
I really think COVID is such a watershed moment for healthcare. And physicians are usually risk-averse people, but I really think we need to put our innovative hat on, Rich. And I think we as in doctors and pharmacists and nurses and therapists, we really need to, COVID or no COVID, we are at the forefront of healthcare, and we need to be part of this transformation. We need to sort of lead the team. I mean, if the users don't create, the creation will not be beneficial to users. That's just my very firm belief. So I think we really need to take the lessons from what we have done in COVID. And there are lots of financial analysis. There are lots of analyses out there. We really need to take a hard look at them and move our lawmakers to make telehealth be more easily accessible for our patients. There is no going back post-COVID without telehealth.
Well, excellent. Well, thank you, Dr. Bandi, and thank you, David, for coming on the call. I really appreciate it.
Absolutely.
Thank you for the opportunity.
If you like this podcast, please click the link in the description to subscribe and review us on iTunes.
You've been listening to the Finding Genius podcast with Richard Jacobs. If you like what you hear, be sure to review and subscribe to the Finding Genius podcast on iTunes or wherever you listen to podcasts. And want to be smarter than everybody else? Become a premium member at findinggeniuspodcast.com. This podcast is for information only. No advice of any kind is being given. Any action you take or don't take as a result of listening is your sole responsibility. Consult professionals when advice is needed.